I really appreciate the opportunity to be here with you guys this morning. I guess it's a good sign. I was here last year and they invited me back, so I guess that's positive. But I've had a relationship here with the Farley Center for quite a few years and referring people back and forth, so I'm very familiar with the the clinicians, the people in business development. They're not only colleagues, they're friends as well. So I'm really happy and thankful, Darlene and Mark and Eric and Don and the physicians, the two Johns, John and Jonathan. I like to come back and visit with everybody. So I'm happy to be here today. So what I hope to accomplish here is sort of give you a snapshot of what I've experienced in my career related to professional boundaries and ethics. And what this entails is we, in the past, have facilitated a 20-hour CME. So it was over the course of 3 days. So we're going to have a little bit of a condensed version of this particular lecture. So I hope to cover it all. I hope to participate, have you guys do some participation. I have some activities planned. And my style is that you can raise your hand, and I'm going to do my best to repeat the question for everybody in the room. And I want you to stop me if you feel like you don't understand something or you would ask for more clarification on this. So I know Gary had a hard time pronouncing the word Hattiesburg, but I'm not from Hattiesburg. Although I worked in Hattiesburg, I'm from New Orleans. I would actually drive up to Hattiesburg. So if you're listening for a Hattiesburg accent, you're not going to hear it. Even though now that I'm in Florida, I'll still keep my New Orleans accent, I'm sure. I have probably 10 generations of family members to hold me accountable if I ever try to lose that. So I'll walk around a bit, and since we have such great microphones here, I'll sort of be moving around a little bit. So I don't mean to be behind some of you, but I'll move around. So when it comes to boundaries, in my experience with professionals is, a lot of them all of a sudden say, really, I didn't know this was a problem. And they say, I didn't know it was a problem, and then it becomes a problem. So the idea that there's a huge blind spot a lot of times in the course of someone's career that has to be, brought to light. Is what my experience is. So why are we so poor at accepting feedback and why are professionals have a difficult time just knowing about boundaries? Well, we're used to being in control, right? Part of why we went to school, part of our university training, part of just being a professional is that you get to have control. You get to make decisions autonomously and independently. And consequently, you can manipulate the rules, and you do. There are times when you manipulate the rules, where you might not chart the way you really intended to, or you may forgive some payment, or you may say, well, this person, my time with them was long, was overstretched last time, so I'm going to cut this session short, or something like that. So you do have the ability to manipulate rules. And sometimes, that's one of the reasons people have difficulty getting feedback. Well, what comes with professionalism is a little bit of grandiosity, some a little more. And that, people come to us. They actually come see us. They come visit us. We don't have to go to them. They actually come to us. And they listen to what we say, I mean, like right now, I'm trying to use my words and articulate my words as best I can as I'm trying to keep you engaged. But like this evening, when I go home and I sit down at the dinner table and I start to pontificate, I'm going to get kicked in the shin underneath the table. And they're going to be like, what are you talking about? You need to come back down to earth. I don't know who you are right now, or something like that. And so the point of, grandiosity is that people actually listen to us too. You go home, sometimes people don't listen to you, or in other areas of your life. We have the ability to intellectualize and our to get through graduate work and professional school requires a detachment a little bit and the use of intellectualization. We're taught to discount our own feelings, to put those aside, and our needs. How many of you have missed work because you were sick more than 5 days in the past year? Very few. I mean, that's a clear example. I mean, I would raise my hand if I had to assess the past 5 years, how many days I've missed. If I missed 5 days in the past 5 years, I would raise my hand. I don't think I have. I mean, it's just, we end up putting our needs aside for the most part, and discounting our feelings. And, the fear that will be exposed if we really do let people, see that we're having struggles. Sometimes there's a fear of exposure. That's frightening. Sometimes we sort of justify things and we're overprotective of the patient. Well, this is for the patient's own good. So that's why I did what I did. Sometimes, we're afraid of feedback and feeling a bit of disapproval. So I tell you this, not to say that everybody in the room has every one of these, but this is just a general list that I've encountered with professionals who have difficulty hearing feedback related to their decision making and their choices and the boundaries that they keep as far as their professional boundaries. So I'm not saying you're on this list, but I hope you consider it. So, we're in this, there's a fiduciary relationship that exists when someone entrusts us with the welfare of them, their behavior, their lives, their addictions, their conditions. And so that automatically is an imbalance of a relationship here, similar to other types of relationships. Now, some of the factors that some of us may experience is that we may have similar issues to people that we are encountering. And so if there's shared issues, sometimes that can compromise our decision making, it can compromise our boundary setting, or our decisions as it's related to ethical choices. What if we have our own addictive process? Or someone in our family, or one of our children, or our neighbor, or someone else. That right there can also compromise. If we have abuse in our history, those things. Not having role models, perhaps, and sort of, that could be similar. We could have the Savior sort of orientation. What about our own religious or orientation or racial makeup? What about our just philosophy of recovery? Some people have different philosophies related to healing, if we're looking at addictions, and just saying, well, that's what we do in recovery. We're supposed to do X, and so a justification there. A lot of times patients will assume that we share the same feelings that they have. So they're projecting onto us that we must feel the same way. So these are just some of the possibilities as far as factors that can impact boundaries. Well, when those do come up, and we have to sort of think about what are some expectations of us. Well, it's common to chat about mutual interests. It builds rapport. And those are normal things. There's crisis going on in our country with the shootings in the church. I actually have a daughter who attends the College of Charleston. And, I've done a lot of talking with her over the phone the last week or so about just the concepts of safety and unpredictability and really what the motive behind the person who did this and the impact that has across so many different systems. And so, it's common to chat about current events, mutual interests. It builds rapport. I'm not saying I'm building rapport with my own kid. I'm just giving you an example of current events that I better have some rapport with her, huh? You're right. So So self-disclosure, we'll get to this in much more depth in a minute, but it can be misused. But, you know, obviously if it's excessive is what I would consider problematic. And just cautionary issues to disclose orientation, religious affiliation, personal history. You know, you have to realize a major part of my career has been on this end of the continuum, working with professionals who have had these problems in their career and working with the licensing bodies all across the United States and in Canada. And it's mainly behavioral issues that I have addressed. And so that's where I'm coming from. I don't mean to like scare people. You know, people go to ethics lectures and workshops and like, oh, they walk out and they're like, oh, I can't do anything. I got to walk. I can't say anything. I'm just giving you some of my experiences that I've had. So that's why when I say, you know, I say caution is necessary. I'm not saying you can't do these things. It's just ask yourself, you know, what is my motive in sharing this? And so if we start to think that somehow we have the ability to offer some special treatment, that is the biggest red flag that, you know, we need to really think about what we're doing here. Because anytime the word special enters into a relationship in our professional lives, that's compromising our ability to consider these boundaries. So special treatment is very dangerous. Time issues, how are we with our time? Are we starting on time? Are we ending on time? Are we flexible with certain patients with time? Not being aware of our own feelings. I'm going to get to how it's okay to have a full range of emotions. And then not recognizing that we can be triggered by our patients, by our clients in certain situations. Even being aroused by fantasies of rescue or even relational fantasies and those types of things. Now, what does the patient bring to the relationship? Well, they tend to place us in a parental role. Now, I'll say a few things about myself at different times, but one of them is that I have 5 children. And so I'm a parent all the time. I can't get away from it, okay? But, you know, so if I'm at work, it's even more. So you're in this role of a parental figure a lot of times. You know, just eroticizing us. Oh, you know, this person has such a wonderful life. Oh, I wonder what kind of vacations they go on. I wonder what they do when they go home at night. You know, I wonder this, I wonder that. Just eroticizing the relationship. These are not uncommon things that patients will bring to the relationship. Passive-aggressive responses and their inability to be direct. We know that. Just this loyalty, like we're brothers, we're sisters, we're together in this. You know, and just the idea of we have similarities. I can tell, and nobody would really tell. You know, this idea that somehow I'm in this relationship with you and nobody would really tell. Like this is our private relationship. They'll bring fantasies of that. They'll bring values, expectations that that's really what we're doing. So, I'm bringing out the need for a little bit of detachment. At the same time, in this day and age, we're expected to be attached in clinical settings. And some of the ways of being attached are being dependable, being consistent, being responsive. That doesn't necessarily mean having poor boundaries with people. Okay? It's healthy to be consistent. Start on time, end on time, have expectations. Being dependable. If you say you're going to do something, doing it. You know, and them being able to come back and forth to you like that secure base. You know, encouraging self-dependence as well as help-seeking. So, you know, I'm here for you, but I also want you to be self-dependent, self-reliant. And not only that, I want you to ask for help. And you can ask me. I'm going to do everything in my power to help you. But there's other people that you can ask as well. So all of these things, even though they seem like, oh, attachment is really questionable as relates to boundaries, no, it actually sets very proper and appropriate boundaries. So being that secure base, recognizing the relationship and the pattern, being attuned, emotionally attuned. How many of us have said to a patient, that really aggravates me when you do this, or that I'm angry that you said this? How many of us tell our patients we're angry at them because of something? Not enough. Okay? Or that's normal. It's normal to be able to express our emotions. This is a relationship. We can't hide away from certain emotional responses that we may have to people. And if they're doing something that is unacceptable and inappropriate, that needs to be communicated to them. Now, you have to do it in a way that is respectful, obviously. You know best how to communicate this, but it's okay to communicate certain, our emotional states with people. That's frustrating that you don't come in here with the homework assignments that we've spoken about. That's part of anger. Now, if we say frustration too much, we really need to ask ourselves, hey, what am I really feeling? I'm feeling angry that you don't do your homework assignments. Yeah.
So it's their life. It's not my life. They can do the homework assignment or not do the homework assignment.
That's right.
And it's their consequence. It's not my consequence. I get paid the same. What business do I have of being angry? Part of their problem is perhaps proper motivation, too depressed to do anything, lethargy, stuff like that. There's lots of reasons they might not do their homework. And who am I to judge them and be angry?
Right. As a human, I'm going to be aware of my emotions. I'm not going to use it as a judgmental thing. I'm going to use it as a part of our relationship. Is this what you want from our relationship? You want me to feel a sense of frustration with you? Do you want that to be the basis of our relationship? I think everything you said is accurate. I'm not disagreeing with you. I'm just saying that I feel that I can still express my emotional state towards them. Even though I agree they're ultimately responsible. But one of the things I feel like I'm serving is a directness of how they're affecting me and how they may be affecting people in their lives. That's ultimately what I'm trying to get at. But I agree, you're putting forth a little bit more of yourself as you expose your feelings towards them. Yeah.
But you also are showing them how to build better skills with their family members, their friends, and their workplace, because you're teaching them that it's okay to express your feelings in an appropriate way.
Right. That's true. Absolutely. Yeah.
I, from time to time, will express so-called negative feelings towards my clients or what the clients are doing. I tend to avoid the A word because, at least around here, my experience, if you say, I'm angry at you, clients will experience that as verbal assault. Now, if I were in the Northeast where I'm from, that would not be a problem. So I just tend to use a milder and gentler word.
So you may reframe the actual word, but yeah. So I have a tendency to be blunt. I have a tendency to be direct, okay? And have a shorter amount of time most of the time in my relationships with people. So I agree. Different people, although I've had outpatients for 10 years. I ran an outpatient group for 10 years. So it's not like I don't have that experience, but the conditions that I'm in now, you're right. I'm a little more blunt, a little more direct, a little more honest, and able to give that type of feedback. But yeah, I think you have to know your client to see what they can tolerate.
I think that if you're angry and owning that you're angry, it's more, for me, about wasting my time, because I can better serve you doing something else. If you're not going to do the assignment, as the example you gave, then can we talk about what you would be willing to do? Because I am frustrated when you don't do, when we agreed that you would do this and you're not doing that.
Yeah.
So can you help me help you find something else?
Yeah.
So that way I won't get angry or I won't be frustrated.
You're right. So my main point is exactly what you're saying, is that I want you to be okay with your emotional states and communicating those. That's part of the relationship. And it needs to be done in a way that you can build on it. And, you know, if you say, well, damn, I should have said this time. Don't worry, you'll have an opportunity again. It'll circle itself back, okay? It's like it'll keep coming back. So some of the other, you know, interpreting the relationship in the context of prior ones, you know, like what is this about, or is this similar, is this different? So that's part of attachment-informed therapy. You know, stretching and challenging is an important part, not just doing the things that we're comfortable with, trying to stretch ourselves, stretch our relationships, being aware of countertransference, and just, you know, the capacity to experience and tolerate uncertainty and doubt, you know, sort of developing that encouragement there. And so, you know, there's a serious compromise going on related to attachment when it comes to the digital age. At least those of us that were trained in sort of, I was trained in more of a psychoanalytic oriented, you know, that was part of my training. So, you know, to think about doing distant type of therapy or online therapy, which is happening right now, and is a big push. Telehealth is major. And, you know, clients actually prefer, you know. So I was tolerating a little bit of this communication in my outpatient practice, and I actually put a stop to it. I'm noticing the uncomfortableness of some of the clients and not being able to access me or send me a text to like tell me that they're late or they have to change an appointment or they're trying to send me an email or something like that. It's very interesting to see the different dynamic. So you have to call me from this point forward. And it's interesting to see how people are. It does complement our face-to-face interactions, you know, the digital communication. It can be a slippery slope. It can open up, you know, like, so, you know, I'm getting a text and I'm like doing X behavior in my own life. That's sort of the slippery slope. Like I'm having to read this and thinking about somebody that I didn't really intend to be thinking about when I'm doing X behavior. So that's the Pandora's box and the gray area that it can open up for us. And then it makes the boundaries much more permeable. It's like, you know, existing, you know, I used to be happy to say, you know, I am with you 100% during our time together. But you need to know when you walk out of here, and I walk out of here, you're not part of, which was partly true. I mean, you know, although, you know, you would see a store or an office or have a reminder like we all do at different times of someone, but it wasn't really I was thinking about that person. And it's a little different with the digital age, if people having access to your information and you. And, you know, there's actually organizations, if you're interested in doing this. I've attended webinars on this distant telehealth type thing where, you know, someone writes their problems out and then once a week you sit down for an hour and you respond to their problems. I've seen that type of therapy go on. You know, obviously the online things, the Skype things, you need to sort of consider what are the ethics and expectations in the different organizations that exist out there related to telemedicine and telehealth. Now, you know, this is big because it's reaching you know, people in rural areas and things like that, but it's going to be more than what we're thinking here. Now, you know, Gary, as he introduced me, you know, part of where I came from, we saw over 2,000 physicians in over the 12 years that I was director of that program. And so some of what I put up here reflects that. Now, our room is mainly full of females, but I want to tell you, we have a lot fewer females having these boundary problems and these behavioral issues in medicine and in professionalism than you do with males. Now, you get a lot of attention. I mean, what do we see all over the national media when a female does something? We see a lot, right? And it keeps playing out, it comes back, and it's a reminder. Not that males aren't on the front page a lot of days, too, but it gets really, you know, played up when there's a female with some of these. So some of the reasons in this study looked at why females have less difficulties: their emotional intelligence, their self-awareness, ability to manage relationships, integrity. Believe it or not, there was an instrument that was offered and sort of looked at different ethical scenarios and how you would respond. Females scored higher than us. This personality characteristics of being more conscientious and empathetic were variables. Communication skills higher. And medicine, they were doing more, they were having longer consultations, so they would actually ask a lot more questions. How long is the average physician visit? Anybody know that? The latest study? 8 minutes. All right. How long is it before the doctor interrupts you when you start talking? 15 seconds. So that's what we've come to. The idea of having a long consultation, that makes somebody feel relaxed and feel really good. I think, my own personal experience, when I go see physicians, they know a little bit about what I do. And so I think they try to overcompensate. They want to sit there and talk to me like, I don't have this much time, by the way. You need to go on about see the rest of your patients. More patient-centered, ask more psychosocial questions. Now, there wasn't a difference between males and females related to mental health status. So that's one thing that we have going for us. But just the idea here, to put this up here, to recognize some of the ways that everybody can improve related to boundaries and responding. Okay, so you live in a small community. You see a couple for domestic violence. She's a nurse. He's a police officer. This couple is doing good therapeutic work, but there's still some ongoing work to be done. They have agreed to continue working on this issue. One morning you're running late for whatever, and you're stopped for speeding by your local law enforcement. The officer turns out to be your client and immediately refuses to write you a ticket, saying, "I am so appreciative of how helpful you have been to me and my wife." What do you do? All right, the first thing I heard was thank you. All right? So how many people are just thanking you and getting out of there? All right, you want to say something? Fred.
The problem is you've got this instant dual relationship.
You got an instant dual relationship.
Then the issue is it's a boundary issue. So then, my inclination would be, of course, in my heart I would run, thank you, but what I would probably say is please don't let our relationship in my office interfere with your best judgment as an officer. I will accept anything you decide to do, leaving the person's freedom intact to make their own decision.
Okay. Did everybody hear that? Okay. He said that he would say, please don't allow our relationship to affect what you would do in this situation, but I will accept whatever it is you choose to do. Okay, so that could be one approach as well. Anybody else? He's still not going to give you the ticket? All right. How many people would say, please give me the ticket? All right. I want the ticket. I want the ticket.
Because it clears the line.
Clears the line. All right. Yeah.
I think if you told him not to write you the ticket, you would be diminished in his estimation.
All right.
That's good.
So if you told him not to write the ticket, he'd be diminished in his estimation there. All right? Any other thoughts? Yeah.
So regardless of what you do in the moment, I think there needs to be a post-processing conversation of, hey, you saw me out in the community, what are the rules, what are the expectations? Regardless of what you choose in that moment of give it to me, don't give it to me, there still needs to be kind of like a follow-up check-in.
Excellent. So that, to me, that's the most important. All right, you're automatically compromising the relationship here. You're doing a couple, right? So the very first thing you need to do when they sit down in your office is address this issue. I saw you outside of here. Even if you get a phone call from someone, you called me between our sessions, and we talked about X, because the couple is the clients in this particular scenario. So yes, you need some kind of analysis of that interaction, definitely. One more comment. Yeah.
best at the beginning, you would have addressed all of this.
Oh yeah, that's even better. That's even better. So informing someone that if I see you out in public, I will not acknowledge you. And don't take offense to that, but I don't want you to have to explain how you know me, and I don't want people around me to be asking me questions about how I know you. I mean, that could be one of your scenarios. I'm just using that. But yes, you use some type of explanation about your policies and procedures, and everybody in your office needs to have that same, your staff, the clerical staff, everybody on down the line needs to have those same principles that you've set up. I'm coming to you.
I'm a child protective service worker and have been for years, and I always told people, if you see me in the community, if you speak to me, I will happily speak to you.
Right.
If you choose not to, I will not.
That's right.
I will not engage in conversation.
So that's perfect. You can say that. I agree with you.
Because then I felt like, if you want to talk to me, because I can know you from my neighborhood or church, nobody's going to ask, but it's up to you.
Right. Okay.
And I would be out to dinner, though, at a different city, and sometimes they would come and sit down with me. Okay, I'm having dinner with my family now, so could you talk to me later?
That's right. So good. It's awkward, but setting that limit. Excellent.
Well, that's kind of what I was going to say. I always had that conversation at the beginning, but they seem more like I live very close to my practice. And I go, my kids play baseball, and I have clients that play baseball. I go to church, I've seen clients there. They're like, they want to come up and say hi. I always tell them, I'm not going to acknowledge you unless you come up to me.
Right.
Because my husband knows what I do. Some strange person walks up to me, he's probably going to guess where I know them. He won't ask. But they almost, I mean, I can say like 99.9 times out of 10, they come up and say, hey, how are you?
Yeah, so there are some scenarios that are unavoidable. Some dual relationships, which we'll get to in a minute. Okay, so to be good is noble. To tell others how to be good is even nobler and a lot less trouble. And so I say this because when this scenario was just put up here, and even some of the responses that people sort of took a risk in saying, there were a lot of people in the room sort of judging and saying, oh, I wouldn't do that. I'm not just driving away from there. Or I'm not saying, give me the darn ticket. Or I'm not saying, do what everybody else, do what you do to everybody. We always, a lot of us in this profession, we're sort of thinking about other people and the decisions they make. And so I'll just caution you about being judgmental of others in these types of scenarios. So you're in recovery. You have been attending the same 12-step meeting for a long time. Just recently you've been seeing a patient who has not been going to 12-step meetings, but has attended some meetings in the past. He does not know you're in recovery, nor have you ever seen him at any meetings. You're having some struggles, and you decide to share at a meeting. At the meeting, you see your patient. What do? You said pray? Somebody said pray? All right. Call your sponsor. All right. Look up the next available meeting. Would anybody think you could just share? It's anonymous.
Share is supposed to be.
All right, so share, supposed to be
And a
confidential.
lot of times at meetings, when people do share, it's a general, it's not a specific event, it's the feeling that they're having.
All right,
I'm
so the
struggling with
feeling.
family relationships, so I think if it's a general
So it
statement.
could be a general share.
It may also depend on the actual client, whether or not you feel comfortable with that client knowing what you feel like you need to discuss.
Okay,
But
so
you
it could be a
certainly want to
specific
follow up
client.
on it.
All right. Yeah.
I've been in that situation. I have always chosen not to share because even if I'm sharing generally, I'm still self-disclosing in a way I would never do in my own office. That's as a yardstick. What I tend to do in that situation is, like, for example, if it's my home group, say, like, I'll make a deal with you. I can't tell a person what needs to attend to, but if we're going to be attending the same meeting, I will not be a therapist anymore. But if you choose not to go to this meeting, because it's my main meeting, then we'll be able to continue. Be able to set the boundaries and the boundaries clearly.
So you would do that in your office?
In the office.
Okay. So you would talk about the boundaries in your office. Okay. Anybody else? This is a tough one. It's a difficult one, and there's many different possible responses. Yeah.
I've had a situation where my sponsor family meets once a month, and they're former patients that are being sponsored by people in that family, and I will not go to that. And my sponsor and other people have, I would say, given me a little bit of a difficult time because that's a much more intimate sharing environment. And so I won't go because I don't think it's fair to them. It's not fair to me, and they will limit what they share because of that, and that's not fair to them. So I have to opt out of that.
So everyone, the key here is sort of sensing what you're experiencing. So if you're in the moment, you have a need, you're in the moment, you see your patient, you have this need, you're struggling a little bit. It's like at that moment, what do you do? It's really what's being asked here. You're being, you're caught between your dual relationship here, your professional relationship, your private life, your private support. So it varies. It depends on the individual, depends on the scenario, depends on the generality, the specificity. You may have set up ahead of time that you wouldn't do anything like. These are guidelines that you need to answer before you're caught off guard. You're not always going to be able to answer every scenario, though, at all. So don't think that you have it all, because you'll be caught off guard in some way, shape, or form. So the intention of these two these two scenarios, are to show you that you can't prepare for every scenario at all, and just doing your best in the moment, and then sort of considering what you did is really what's important.
This particular question, I think in some ways we're being slightly hypocritical now.
Mm-hmm.
We don't share, because what do we tell our patients? Oh, what if I walk in there and I see my neighbor? What if I walk in there and I see so-and-so? I don't want to share. And what do we tell them? Anything you put before your recovery, you will lose. And as a therapist, self-care of my own program is just as important as them taking care of their program. So I think in some ways, in this particular scenario, we have to think about the recovery program also, and then how my recovery program, if I'm in recovery, is separate from my professional program. And I think that's something you can address later, and if you want to not be that person's therapist, that's a choice. However, again, in the community that I live, where I live and work, either I would never be able to go to a meeting, or I wouldn't be able to have any clients, because they're all going to begin the same meetings. So at some point, those relationships may overlap, and a lot of people in recovery have that situation.
Yes, your points are excellent, but they're probably different than most people in the room. Everybody's going to have a different approach to these. That's my point about ethics. There's a big gray area, and you don't know it's a problem until it's a problem. And some other people may adopt a different philosophy, and there's nothing wrong with that. They may have a much stricter boundary about their personal lives or something like that. It varies. But the key is to just consider the possibilities and don't think that you can prepare for all of them. So this article is one of the better ones in that it gives a number of scenarios, and they actually did research on the clinicians about how were they able to understand and respond to different boundary scenarios like we were just exposed to. Part of it had to do with their knowledge. So how many of us have read our Code of Ethics in the past 6 months? You must have been studying for your licensing or something like that, huh? That's some sleepy reading, huh? Or if you get some changes or something like that. But the idea is that, not many of us are rushing to Barnes & Noble or Amazon.com and getting a book shipped to us on ethics. But we do need to try to stay up to date with this. And so knowledge is a part. I actually recognize a few of you from last year, and I did almost the same lecture. But guess what? I'm a year later, you're a year later. You're going to hear something different, I hope. I'm going to say something different, I hope. And we need to be reinforced. It needs to be reinforced most of the time. So our knowledge base always needs to be refreshed. That's why most of us, it's required as part of our license renewal. our comfort. How are we in situations and scenarios? How comfortable are we if we see someone at a meeting and we're having a struggle? If we get pulled over by someone, how comfortable are we communicating the person crossing our boundaries, whatever they are, showing up late, not paying their fees, being disruptive in our session, being disrespectful to our help in the office? You know, I mean, how comfortable are we with addressing these things? Or even our own self, how comfortable are we, you know, saying some things that might be challenging in our own lives that we can't say, but how comfortable are we communicating these? What is our experience with this? You can't experience everything. Even if you have a long career, you still won't experience all these scenarios. But you will gain experience over time. And so, you know, for example, I can remember in that psychoanalytic training, I got a couple of gifts from, I would have psychotherapy patients for a whole year. And so at the end of the year, one of my patients brought me a book, and it was 1,001 questions. And he sort of handed that to me. And so I was like, So I didn't really know what to do with this, you know. So I bring it to supervision, and they have a field day, all these faculty members, you know. Just enjoyed the idea that, okay, this person, you got to know all this stuff about this person the past year. He may be wanting to know 1,001 things about you. Or he's like saying, you're so young and green in this field. You really need to explore these questions about yourself for the rest of your career. So there's all kind of spins that it could have had.
He was happy what he learned from you, and he wanted to share something that he had also experienced with you because you had taught him.
There you go. So it could be all kinds of interpretations of that. Then I had another client that same year of training that brought me I helped her and her daughter. She was going through a divorce. So it was a little bit of a transition here, I tell you that. And she brought me, you know, back in the day, it was like an actual calendar that you would put like a year's worth of papers in. It would be like a little leather folder here. And so, you know, that I kind of had a little more of an understanding that, you know, she was kind of wanting me to think about her maybe the next year, each day that I open this thing up. So I used that to sort of interpret a little bit, or that I was pretty disorganized as a student and I needed better organization. But the point is, I mean, these are all experiences that you know, as a gift-giving types of experiences that I experienced there. And then lastly, our process of decision-making, which I hope to cover here. Ultimately, you're a professional. You've chosen to sit in this seat today. You've chosen this path, okay? There are consequences for this, all right? Now, maybe you're all happy and wonderful when you were down the street at, you know, the university here and getting your training, but there are consequences for this particular field of practice. And we'll cover some of those, but you know, you as a professional are expected to live up to these standards, which is to master this body of knowledge of science and the arts, to govern yourself by your code of ethics, you know, society really needs and wants professionals. We have to have them. They trust us. They lean towards us. There's a trustworthiness in a professional. The person is dedicated their training, their career to X behavior, whatever the profession. So there's status given in society by you know, society trusts and gives you a status. And you know, this professionalism is both individual and group. So when people do things that affect the ethics, the code of ethics, it affects all of us in this room, not just the victim directly if they have a direct victim or their own family or something. Everybody in the room. Oh, that's what that profession is. It's a bunch of this. You know, it's a bunch of this type of response. All right. So now's the time for you to start being tested. So what I'd like you to do is maybe on the back of your handout, write, I'm going to ask you some questions, and this is private, or you could use your Farley notepad there. So I'm going to ask you 25 questions over the next hour, And I want you to write your answer down. Your answers are only going to be N, R, S, or O next to a number. N, R, S, or O. So when I say the statement, you're going to say never, or N. Or you're going to say rarely. Or you're going to say sometimes, or you're going to say often. That's all you're going to write. All right. I have told patients personal things about myself in order to impress them. Yep, that's number one. I have told patients personal things about myself in order to impress them. Number two, I have accepted social invitations from particular patients outside of my scheduled clinic visits. Number two, I've accepted social invitations from particular patients outside of scheduled clinic visits. Number three, I've used language other than clinical language to discuss my patient's physical appearance or behaviors I may consider seductive. Seductive. Number three, I've used language other than clinical language to discuss my patient's physical appearance or behaviors I may consider seductive. No, it would be like with your colleague. Not to the, this isn't to the patient, it's to a colleague. Like, that is a very seductive shirt you have on today, Mrs. Jones. No, you're telling your colleague, boy, did you see the way so-and-so was dressed? Like a blah, 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 and the way they, they behaved and the way they flaunted themselves and came up to me. That would be an example. All right, number four. I have found myself comparing the gratifying qualities I observe in a patient with the less gratifying qualities in my significant other. Number four, I have found myself comparing the gratifying qualities I observe in a patient with the less gratifying qualities in my significant other. Then number five.
Is that you just noticed it, or you actually did or said something?
Don't MMPI these apart. Just do your best to write never, rarely, sometimes. If you've had that thought, I would say it's rarely. Okay, it's at least a rarely. All right, number five. I have thought that my patient's problem would be helped if he or she had a romantic involvement with me. I don't have to repeat that one, all right? All right. So nobody can change their first responses here. We're going to get to all of these. But let me just go back and explain a couple of these. So I've told my patients personal things about myself in order to impress them. What's wrong with that? All right? Gary, he gave you a snapshot of my bio to sort of tell you who I am, so that I could stand up here and you would be attentive to a certain degree, right? You might not walk out immediately, all right? You can't get your CEs unless you stay the whole time. But no, seriously, like, what's wrong with saying personal things about yourself in order to impress people? All right.
Is that different than credentials?
It could be different from credentials. That's a great statement.
Because it's about you, it's not about the client.
It's about you, it's not about the client.
I was saying the same thing. They were saying, this is where I have areas of expertise where I can help you. That's different than saying, look how great I am.
That's right. All right, good.
A little arrogant.
What is the purpose of telling?
What is the purpose of telling? All right, so these are great questions to ask yourself before you decide to disclose something. Okay? And, I mean, I've worked with a very skewed sample. All right? I already told you. My whole career has been skewed. I'm like, I should be standing like this right now, okay? Because it's been a very, yes.
But isn't this where we can change our rules and we say, oh, I'm telling them this so that they will respect me, even though internally you might be like, I'm telling them I'm a credentials because I want them to like me or think I'm a good counselor.
Right.
Kind of, we could change our own rules here and say, justify the reasoning why we need them. We may change the word, but the value might still be the same.
Yes. Yes.
Instead of saying impress, I'm trying to prove something. It's like, well, that's still the same. What is it about me and not about them?
So there's a certain amount that you want to impress or prove to someone your credentials or something like that. Yeah, you're changing the word. Absolutely. So as a rule of thumb, I have about 5 things that I will tell everybody. Okay? And if I get outside of those 5 things, I have to ask myself, why am I sharing this with this person? What's going on with me that I'm sharing this? That's all. I'm not saying you can't share it. I'm just saying you need to ask yourself, what is my purpose for sharing this? And, you know, whatever those 5 things are, you need to keep them, you know, whatever. I'm not saying you only need to have 5 things. I told you, I work with a skewed sample of people. So consequently, I have just 5 things. You may say 10. The key here, though, is universal. You cannot say, I'm going to share 5 things with you, 5 things with you, 5. No, it doesn't work that way. That's the specialness that I was getting at. Can't be that way. So think about disclosure related to, of course you want to be qualified in your work. Of course you want to say things to you know, sometimes sharing recovery. People sharing that they're in recovery is a way of quickly getting to a relationship. Some people use that. What about accepting social invitations? What about if someone like graduated from, they got their GED and you worked with them you know, significantly when they were in detention or something? Or what if someone invites you to their bar mitzvah? Or, you know, you're in a soccer field. What if you're, you know, going to a birthday party? You know, we're going to a birthday, you know, my child's having a birthday party. I'd like to invite you specifically to it. So what about this accepting social invitations outside of visits?
I actually didn't do that. I didn't let my daughter, I didn't tell her why, but someone went to the same preschool where it's a client of mine, and her child had a party, and I just said, you can't make it.
Yeah. There's 30 other students.
For me to be at her house.
Yeah, there's 30 other students. Okay. So anybody, any thoughts about that one?
I think it depends on your situation, because as a CPS worker in foster care and
right.
family prevention, you know, I went to kids' graduations and I went to their special things if they invited me, because why you want your CPS worker there? But, you know, it was important to them because we got to this step, because we worked step by step to get there.
Right. So different people have different relationships with people, professionally. What about deaths? Funerals?
When I go to funerals, when they ask me, I go with you.
All right. So are you going to go for every patient that dies?
If they ask me.
I've had a few patients, since I've worked in substance abuse for 40 years, I've had a few patients invite me to their 1-year anniversary AA meeting, and I always have told my interns that they need to go to AA meetings and Al-Anon meetings to get to understand the situations. So I have gone to a few anniversaries.
Yes. Okay, that's fine.
As a rule, I think it's generally not a good idea to accept social invitations. But I can remember one situation within the last year. A client has worked very hard on individuating, working on her self-esteem, and it turns out she's a wonderful artist. She's a great painter. And she had her first art show last year, and she invited me. I thought it would be a real affirmation for me to come, and I did.
Sure. So you have to make these decisions. Just be aware of the decisions you're making. And I'm going to give you some safeguards later on about, you know, one of the keys is be willing to write it in a chart. If you're going to do anything outside of the office, be willing to write it down in a chart, or today type it into the electronic health record. Yes?
I was going to say, I do in-home work,
Oh,
so the boundaries are very blurred. And I'm a supervisor, and one of the things that I'll say to folks is that if you're going to go to a graduation party, or if you're going to go to something that you're invited to for the family, don't bill for it. But write a non-billable note that you were there, but don't bill for it.
Okay.
And only stay for a short period of time. Go, make presents, say your congratulations, and then leave.
Okay. There you go. So using clinical language to discuss your patient's physical appearance. The key with this one, I mean, the word it says seductive, you know, behaviors considered seductive. I mean, those are loaded words. But if you start to use language that's not clinical, that's a sign that you may be having some boundary issues with this person. So that's an example. And what we know from research is that the farther, geographically, the farther away you get from your office, actually the more likely you are to cross boundaries of patients, to share things to breach confidentiality. It's like this mental thing. Oh, you know, I'm not around the office anymore, so I don't have to worry about X. I'm not around the people anymore, so I don't have to worry about Y. Well, that's not true.
Can I just ask a quick question? When you say seductive, you mean like, he looks nice, not like, did you see this?
Yeah,
Because to me,
like you saw, he was shaking his ass. Like he was really shaking his ass, you know. And he was like, he sat with his legs wide open, and you know, that's not really.
If you're just saying her pants were like really tight, that's a bad creation?
No, I mean that could be descriptive.
I think it looks good.
Yeah. I mean, again, would you write some of this in the chart? So you could write something about the person's dress. Yeah, you know. Drawing attention to genital area would be something that you might write. All right, so this one's not so off right here. I know I used it as an opportunity to make a joke, but it's something real here. I found myself comparing the gratifying qualities I observe in a patient with the less gratifying qualities of my significant other. Hey, I mean, man, what you did, I'm sitting there listening what you did for your partner for Valentine's Day. Damn, that was nice. I wish I had some of that, you know. I mean, the point is, the relationship that's our tools. Okay, we're not above being able to like say, "Wow, that seems really nice." Paying for something, drawing me a bath, whatever. Whatever it is, it doesn't mean you have to be a never on it. Oh God, no! I would never think about. No, I mean you live. You have a life. You have relationships. You may hear things that people talk about that are like, "Wow. That sounds very nice. I wish I had some of that," or "I'm glad I don't have any of that." So there, I'm not saying you should have a rarely or an often. I'm not saying any of that. But don't rule these things out. That we don't make subtle. I'm trying to bring things to your awareness. That's my main point here. Yeah.
I often do the opposite. Like if I hear a patient discussing something in group about something their spouse said that was very negative, I find myself at times getting really irritated, about that's not right. Like what, especially if there's domestic violence that happens. So I kind of go the other way. I don't look at, oh, that was really sweet. I look at, the opposite, more negative stuff.
Yeah. Yeah, we have a tendency to have a more pessimistic view being in this field. So it's not uncommon to think suspicious of people. Oh, I wonder what their real deal is,
I also find myself, I have to think the other side too, that patient is giving their view of that, and there's always two sides to every story. So I have to remind myself of that as well, that person is not totally innocent, and not that anybody deserves obviously to be in a domestic violence issue, but at the same time, there's always it takes two to tango.
Right. Okay, we're going to take a break. I'll get you to come back in 5 minutes, 10 minutes, 10 minutes. Okay, I want to get started again. I want to be principled when it comes to your time, so we're gonna get back going. So I have a lot of slides to cover in the next 40 minutes. We'll get through it all, okay? I can assure you. And plus you have the handouts to take back home, so you certainly can read through a few things on your own. But my point is to try to highlight a lot of what we have here. So essentially, what we all know is that part of the ethical principles have to do with, doing good, not harming, allowing people choice, being equitable, and being loyal. Those are the expectations as professionals that we're all expected to follow. And so depending on whatever our own code of ethics are, that's where you sort of need to turn to specifically to look at what the expectations about your specific organization is. There's just a history of ethics over time, in that at first we just used religious and spiritual and morality issues, and then it became more of you know, we believe in the individual and the principles that people have a right to make decisions. We start to put value on people and say that people deserve certain types of treatment. You know, like I just read a feed about the, bless you, the Stanford prison study. They're making it into a movie. It's going to be released. Philip Zimbardo, you know, where they assign half of the people to be prisoners, half of the people to be guards, and they sort of let them behave. And well, they're making a movie about this, and it's going to be released in 2016. So anyway, that's where some of this values and principles came from, is being able to implement, you know, IRBs and stuff like that. It became more important. And what we're in today is basically a risk management period where the legal and the professional have intersected. So a lot of things we're doing are defensive type things as it relates to ethical decisions and principles. You know, there are values based. It's laden with our ethics and the things that we value. You know, there's like life-ending types of goals that most of us probably have. You know, of like happiness and inner harmony and quality and just love and respect and those things. Then there's instrumental values. What are you doing to get to those? So this is a way of, you know, being cheerful, polite, responsible, honest, those types of things. Again, more just embedded as far as where the principles are. This is really the basis of medicine and the helping profession. And that, you know, we're really encouraging people to be autonomous and think for themselves and being in their best interests. We're really, you know, expected to do good, to not do harm, to do no harm, and not, you know, non-malfeasance is just sort of what you participate in is in the patient's best interest. You're not recommending a treatment or an intervention that's not in the patient's best interest. So there's a, you know, fidelity and justice. It's the rights and responsibilities. Yeah.
Well, in real life now, I teach, and one of the things that in development, it's like I show the movie The Medicated Child, and it seems like so much of the research is being, the engine is the pharmaceutical companies. And, you know, I try to teach my students, you know, that you always do medication if you need to, but also I was taught you always do talk therapy. You want to minimize. And in this movie, it actually shows, it's a documentary that the doctors, the mother will say, well, is there anything else we can do? No, we're just going to up the medication. And it is so blatantly dangerous to everything I've been taught, medicating these children without giving them an option of something else. Also, these doctors, you know, then you see the mothers at home giving the kids the junk food because one of the things are that, you know, their appetite is increased. And it's like, where are ethics these days? And the guy will say, yes, I work for the pharmaceutical company, however, it doesn't interfere. Of course it interferes.
Right.
So it's just very hard, I think, to maintain and teach students that there are ethics when it's so blatant that there's not.
Yeah, so the comment is mainly about the impact of pharmaceuticals in the helping profession and the mental health field, the addiction field. And while there's been a huge pendulum swing into, you know, really relying a lot on medicine as it relates to these interventions, there's a subtle shift that's happening. I mean, what's being required now is that mental health get integrated into medicine. And so there are actually models out there where, you know, in a primary care's office, they have a clinician, a mental health clinician, that as they assess someone, maybe outside in the waiting room, they have a little iPad and they answer 10 questions about depression or anxiety. So when they come into the examination room, they're getting a little bit of that history. If the physician feels that there needs to be some more mental health type intervention, they have a little office set up. They have them sit in the waiting room. They go, they visit with the clinician for 15, 20 minutes, do a rapid assessment, and then the clinician goes to the physician and says, hey, these are the things that I think is going on with Mr. or Mrs. X, and these are the recommendations. And it could be going to some self-help group. So there's been a little bit of a shift with the Parity Act and you know, that they're trying to do better at integrating mental health and talk type of therapy with medicine, because it has gone in the direction. I mean, I know. I teach at LSU Medical School. I see the psychiatry residents, the third-year psychiatry residents. I've been teaching them since 2000. What I taught them back then is so different than what I teach them today. So there has been a huge shift as far as the pharmaco interventions that are expected in our field. So absolutely, it's a good point. And, you know, the idea of who's guiding the ethics. I mean, what happens with ethics is that if you have enough people affected or impacted, then they start to make some subtle changes. So in the past, the pharmaceuticals, they would pay for all kinds of things. People would go to these, you know, conferences. They would never attend them. They'd be out vacationing with their family. Now they can't offer anything. They can't even offer an ink pen or something like that. So it's very strict, and it's very different today. So there are guidelines that do exist, and you know, I think the public is having a say today because we're much more consumer-driven as far as medicine. So back to the fidelity and the justice, and the degree of which you promise to do is what you actually do. So don't promise to do something that you can't do. This is just that, you know, back to our questionnaire. I'm not going to talk about that other one because it has to do mainly with physicians. All right, number 6. I have found myself trying to influence other employees in my workplace over whom I have supervisory influence to support political causes or positions in which I have a personal interest. I can't read that one again. It's too long. All right, number 7. I have felt a sense of excitement or longing when I think of a patient or anticipate his or her visit. Number 7. I have felt a sense of excitement or longing when I think of a patient or anticipate his or her visit. Number 8. I have found myself talking about my personal life or problems with the patient and expected sympathy. Number 9. When a patient has acted in a manner I consider seductive, I have experienced this as a gratifying sign of my own sex appeal. All right. Number 10. I have engaged in a personal relationship with the patient either while I was treating him or her after the treatment was terminated. Engaged in a personal relationship with the patient. That's 10, okay. So real quick on these, number 6, I found myself trying to influence other employees in my workplace over whom I have supervisory influence to support political causes, a position which I have a personal interest. You ever offer free tickets to go to a political rally or your church potluck? You ever bring in your kids' candy and put it there for people to buy? Some people use a whole philosophical approach in their business structure and their business model that may support a certain political cause or personal interests. I felt a sense of longing, a sense of excitement or longing when I think of a patient or anticipate his or her visit. All right, listen.
We have an alumni weekend twice a year here, and I get very excited when I see former patients that come back and they're really excited about their recovery and they're doing really well, and they're really involved in different things in their recovery. That excites me to see that for their benefit.
So we all need a little emotional bank vault that when we get nice cards and nice letters, we should put them in one spot. And we're having a difficult day. And
over 18 years, I carry it with me wherever I go, and I keep it.
Good.
Because you just never know when I might need to go and look at that.
That's right. So it's normal to feel excited. I mean, some people do all their homework, right? Notice I got some kids, huh? Some people do all their homework. So, of course, I'm much more excited to see them, perhaps. So they do everything I say. Makes my day a little bit easier.
Or you're worried about them and you're glad to see that they're still alive.
Yeah, there you go.
And the bad one.
So just the key here is longing. That's a strong word. And anticipating. So, you know, I'm going to dress a little nicer this morning to go into the office so I can get this type of potential compliment. Or, you know, I'm going to do A, B, or C. I'm only going to schedule this patient after all the staff are gone. All right. Number 8, I found myself talking about my personal life and problems with the patient and expected sympathy. What if you have had a similar condition to a patient, or you've had a similar life experience to someone, and you tell them that? All right. So can you share that? Can you ultimately share that and not expect a certain amount of sympathy? I don't know.
Is that like appropriate self-disclosure?
I don't know. I want you to think about these things.
Would you write it in the file?
I'm not the answer man today. I'm the question man. All right, last comment from you now.
There's a staff member we have here who very tragically lost his child. And when we have had patients who come in who tragically lost a child, he will share how that impacted his recovery and what he has done to stay sober, because that patient or patients have thought there's no way I can move past this.
Right.
And that has been incredibly beneficial for them to talk to this person about that. And he will talk to anyone regardless of what program they're in. It doesn't matter.
Right.
But he's not doing it for the sympathy. He's
Right.
doing
Exactly.
it for the help. So
Exactly.
it depends on why you're sharing it.
Exactly.
Now,
Which is what I was
granted, as a
thinking
human
too, is the
being, you would
motive.
expect somebody to be sympathetic to that.
Right.
And you
So-
might get upset if they're not.
So
But
this.
that's not his intent of sharing.
So about 3 months ago, an American medical journal, JAMA, a Journal of Medicine, there was an article about a physician who talked all about the rationale for disclosing something like you just said. And the very last 2 paragraphs were the points of why it wouldn't be helpful to disclose something like that. And it was a surprise to me, because I thought, you know, most of his article was about disclosure. And then at the end he decided not to disclose something like that, and he pointed all the ideas out about the benefits of doing that as well. So there's not one way, but you can choose some other way here. All right. So number 9. When a patient has acted in a manner I consider seductive, I experience this as a gratifying sign of my own sex appeal. It's a little self-centered. And engaging in a personal relationship. I mean, what if you bought a car from someone? What if you went into a business endeavor together? Yeah.
So one time I had a client who was a minister and was also doing some counseling at a hospital. And his supervisor was quite upset with his informal manner with the patients and their families, and would go down to the canteen and have coffee break with them, and all this familiar stuff. But it turns out he came from a small town. So if the car dealer was his client, if he didn't buy the car from the car dealer, that would be more of a transference problem than if he did.
Right.
And also, you're going to go to barbecues, and you're going to be at the same church, and you're going to do all these things. And really, it's a whole different situation, and you have to navigate it in a whole different manner.
Yeah. So when you're talking about somebody in the spiritual counseling, the spiritual realm of counseling, then I think that there's a different expectation a lot of times in our society of someone like that. And with health and stuff like that, you're dealing with something a little different as crisis management and all of that that's going on, but still the relationship expectations are usually a little different. I agree with you. Okay. I got to move on here. So even though, Congress could probably benefit from this ethical model here, this is an actual person named Congress. It's just, examine the situation, think through it, hypothesize the outcome and the pros and the cons, identify an intervention, and then if need be, consult with someone else. Get another person's opinion about one of these decisions. Oh, I'm sorry. Then you should examine your what happens. It's just another model. Ooh, that's jumping around. And so what we're noticing here today are that boundaries are not like these clear, even though this is very dated, this is still accurate. And the latest book that these guys have written is very similar. They're saying the same things, is that, they're not these bright lines that are clear. They're very ambiguous types of lines. They're movable. They're highly context dependent. There's no hard and fast response. That's what we've been learning through some of these examples this morning. I do think, though, that there are areas that you should really consider about your own boundaries. And time is one of them. And be respectful of your time and the patient's time, the client's time. And that needs to be a boundary about how much time you're willing to spend with someone. Your role, even though, the person I am standing here is the same person I am in my personal life, my professional life, I still have different roles and different expectations and different requirements. So you still can have boundaries around the different roles that you have. Places, I think it's, maybe for the minister in a hospital, it's more appropriate to go to the canteen or the cafeteria. But I think doing therapy outside your office could be a problem. Now, obviously, you're in a home, and that's a little different. I mean, that's a model that's being utilized. But think about place. Think about your space. And think about the boundaries in your space as well. Gifts, physical touch, think about that. And what's okay, what's not okay. Money is part of that fiduciary relationship. That makes this a fiduciary relationship. Yeah.
You didn't emphasize much about gifts, and that seems to be the challenge. Like you mentioned the guy gave the book.
Yeah.
How do you handle, because clients do that, they
Right.
bring you stuff that they think is going to be nice.
Right. So I have a slide at the end on that, but we probably wouldn't get to it. So quickly, what I would think is that the value of the gift and the meaning of the gift. And would taking the gift be more detrimental if you refuse the gift, or would it be more detrimental if you accept the gift, depending on the relationship? So somebody's bringing, peaches from their garden, and then, you have a policy that we share these gifts with everybody in the office, so we'll put it in the common area. That's what needs to be communicated if that's the case. And then some exploration as to why this person feels a need to give a gift and what type of gift that they're given or something like that. So, and then the value and the meaning, it's a lot different. Somebody giving a book or somebody giving something that's expensive or something like that. The language you use, I already talked about this. Professional clinical language is what's important. It maintains a boundary, actually. There's cultural variations. There's whole, entire sections that you have to take to keep your license active that have to do with cultural issues. So being cognizant of that, and even geographic. I mean, heck, I'm up north right now, you guys. I'm in the north compared to where I live and where I'm from. So boundaries keep safety and predictability. So, I was trained in hypnosis, and I would always tell my patients that, if I was to we're going to go through this process, I'm going to stay sitting right here, I'm not going to get up and move, you're going to be aware of what's going on around here. If I was to have some type of, physical or medical event, and I was to fall out my chair, you would be able to hear that and hopefully go outside and tell somebody I fell out my chair. So I would try to coach the person about the expectations because I wanted to create a safe environment. So just telling people, I expect that you're not going to destroy my office, you're not going to take anything from my office, you're going to do A, B, and C. I expect you to pay at the end of the session. Whatever it is, you know, it creates, that boundary creates that sense of safety and predictability. We're not going to be able to cover all these. There is a difference between boundary crossing and boundary violations. How many people in the room have committed a boundary crossing in their professional life? I'm going to raise both hands because I've probably committed multiple ones. Most of us have, okay? And those are not necessarily a part of the treatment, but they're not necessarily harmful in some way. So even disclosing something could be a boundary issue. Or when you've been vulnerable and you've acted in a way or behaved in a way, as we've already mentioned, that could be a boundary crossing, actually. Boundary violation is harmful and exploitive. That's much different. So here are some of the specifics related to boundary violations. All right, let's get to back to our instrument number 11. I think about what it would be like to be sexually involved with a patient. I don't read that one again. Number 12, I've initiated or engaged in a personal relationship with an employee that I supervise. Personal relationship with an employee that I supervise. Number 13, I have taken great pride in the fact that such an attractive, wealthy, powerful, or important patient is seeking my help. Number 14, I have found myself talking about my personal life or problems. We already covered that one. Number 15, I've resisted or refused consultation from appropriate professionals when others have told me that I have problems that cause difficulty in my work or personal relationships. So I've resisted or refused consultation with appropriate professionals when others have told me that I have problems. All right? We're not going to talk about any of those. Moving on. There's more on the boundary crossings and the boundary violations. So what about the dual relationships? I already said that relationships are part of our tools. They're our instruments. We have a biological instinct to be in relationships, not to be isolated. Okay, so this is just a natural part of who we are, you know. That's why I like having breaks are wonderful at a conference like this. You get to talk to people, you get to share with people who you may see occasionally. You don't have to go through the elevator spiel about what you do for a living. Okay? I've been practicing for 25 years this year. My wife, she still doesn't know what I do. And I have no real need to explain to her. As I said earlier, there are certain components of this profession that you've signed up for. And some of it is a little bit of isolation, that you have to be the receptacle of certain parts of people's lives. And you might not get to share that with other people. And that's why when you come to a place like this, everybody deals with it. So you can, the breaks get stretched to be longer, you know, because it's like, hey, you know, let's chat it up a little bit. It's much easier to have a conversation in these types of rooms because it's natural. So there's obviously societal and cultural influences related to relationships. Our internal models of what we believe people are and what we expect in relationships, those are present. And then our own awareness. Addiction work has a little more risk with boundary issues, you know, especially when someone has their own recovery. How much disclosure to do is a question mark. And when is it appropriate? When is it destructive? When it's unethical? I'm not sure. We have to continuously be questioning and talking with people and talking with our supervisors and talking with our colleagues about what happened, different scenarios. We always need to follow our code of ethics and obviously the law. And, you know, too much information about a client is equally problematic. You know, sharing this information can be problematic in an addiction standpoint. So, you know, there's the old story about the sheik crossing the desert there, and you know decides it's time to pitch a tent, and so you know he pitches a tent. He's by himself. Now I know that's a fancy for like one sheik to pitch, but that's all I can come up with online. And so the camel, about midnight, sort of puts his nose through the curtain and says, "It's really cold out here. Can I just leave my nose right here for the rest of the night?" "Oh, sure. Leave me alone." So about 2 hours later, the camel, "Psst, psst. Hey, can I put my ears inside this tent here? Just right inside this curtain. I'll leave the rest of my body out here." Well, we're seeing where this is going, right? And, what ultimately happens is, there could be problems. The key word that I mentioned earlier is specialness. Allowing more time, scheduling at the end of the day, forgiving debt, taking gifts, disclosing more. That's called special treatment. It's okay to be attracted to people. It's okay to have a full range of emotions towards our clients. If we have intense attraction, we need to probably refer and do something different. So intense attraction, if you have it, you have it. There's no reason to deny it. Believe me, there's plenty enough patients out there for you. If there's professional isolation, Fred brought this up earlier. If you're in private practice by yourself and you don't have a lot of people to bounce things off of, you're in a little higher risk. Okay? Excessive self-disclosure increases your risk. If you have behavioral changes, we all have a certain workflow and a certain exchange that takes place. We might go here, wash our hands. We might go get some water out the water cooler, whatever it is. We have a certain ritual that we do in our day-to-day practice. If we start to change that behavioral pattern, that could be a sign. Okay? If we're doing something a little different, that could be a sign. And then, making certain exceptions, offering free care. These are all physician-based, but, allowing food or drink makes the relationship a little more casual. Having it at a coffee shop, those types of things. All right, back to our questionnaire. We're going to finish it, I promise. All right, we're on number 16. I have initiated or engaged in a personal relationship with the person over whom I have power, authority, or decision-making ability. So this isn't necessarily a patient. I've initiated or engaged in a personal relationship with the person over whom I have power, authority, or decision-making ability. And 17, I have asked one or more patients to do personal favors for me. Number 18, I found myself trying to influence my patients to support causes, business deals, or positions in which I have a personal interest. Number 19, I have initiated business deals with patients. And then number 20, I've solicited gifts, bequests, or favors from patients for personal benefit or to benefit a business in which I am or plan to be involved. Okay. What you think is private is not. All right? So, we often think, well, our job is so important. We have these really important relationships, which is true. Nobody else will ever hear this information. Nobody else will ever know this information about this person, which may be true. But believe me, what you think is private is not. Okay? And I'll tell you that from experience. So you go to the court of law in certain scenarios, and your relationship and the things you've done will come out to the public. If someone files a complaint against you to your licensing body, that can become public. I mean, come on. You get the newsletter. Don't we all turn to the back page and see who did what, what statute and all this? Grievances in the workplace can easily become public. And then obviously report. I mean, most violations of licensing bodies and licensing boards and things is all online. We actually just did a study of professional sexual misconduct and professional sexual boundary violations, and we looked over a 20-year period, and every single data point was off the internet. And we had hundreds of people that we were able to track how quick they got their license back, which state handled them in which way. We did all of this just on the internet. That was our only data. That's how we got the data. So what gets reported to your licensing body is public. When your ethical principles come in conflict with the law, it doesn't matter which state you're in, do what you can to resolve the ethical conflict. If the law ultimately supersedes your guidelines. So, although you may have, like, I'm not going to disclose this because of my ethics, but if a judge tells you, you got to give me your, so if you're subpoenaed, now lawyers will subpoena you. I just have a general rule that I'll respond to that and say, if the judge requires this, so the judge is the one that you sort of release this information to. And then the judge often will recognize the sensitivity of the material, and they will just hold it themselves and not release it out into public. They will read it and stuff like that. I'm not a lawyer. I'm not giving you legal advice, but you do need to follow the law. That's one thing I would tell you. Yeah.
When I first came down here to Virginia, I got a lawyer called or sent me a letter from Suffolk, I don't know if you know where that is, on the river, and wanted me to release information for his client whose wife or husband was on paper. Of course. And I called him and told him that I couldn't do that. It was against federal law. He said, well, we're in Virginia and we don't go by federal law. I never heard from him again.
Yeah, that's a good response.
Somebody recently put, I'm on a professional Facebook.
Yeah.
And somebody recently put up this ethical quandary. She had a patient that she was really well pursuing him, that he was wanted by the FBI, and he contacted her. What her question was she ethically bound to report it to the FBI? Most of us thought no, but I'm just curious.
Oh, I don't know. Let's do a show of hands. So if the person is wanted by the FBI, you have this information, they show up on your doorstep, or do you feel like you would report that to the FBI? How many people? All right. So about it's not. I think more people are saying no. I would say no initially, and then I would have to be convinced why I should report this person.
Well, I was just saying, if the FBI comes and says, do you know anything about this person, now that's a whole other situation.
Right, where you legally have to
but
I mean, if they just come to your door,
well, you might
is that
ask,
different than if they give you...
That's true.
Yeah, but
so if they just come to your door versus giving you a court order that you have to follow through with this.
Well, I think I would tell them that I would want a lawyer here before I answer any question.
Sure. You can always call your licensing body and give them a hypothetical. So you might want to get on the phone and just say, look, I have a client that A, B, and C, and this is the scenario. And they'll tell you. They'll give you, And then I've done that a few times, and then when I read the newsletter, I see the hypothetical in the newsletter for people and say, oh, there you go. They use it to teach other people. Yeah.
Well, I was trained that, when you have a session with a client, you always tell them that you are going to have to report some sort of felony. And so I always, tell them that, and I say, are you suicidal, are you homicidal, do you want to hurt somebody? And I document. And, they have the option to say no, and I documented it. But if they said yes, I think that I'm legally, bound with certain issues.
Different states have different rulings on this.
Oh, I didn't realize that.
Yeah. So, to say a felony, I've never said that to a patient. They might tell me they killed somebody. Child abuse. Yeah, that's different. Yeah. Right. But yeah, so the law, this is the key here again, the law supersedes our ethical guidelines. One more comment.
So what if you have some law that to you, complying with this directive from the court would be a gross violation of your ethics? So, because the court said you should do it, you should do it without any culpability of your own?
Well, you're part of a group. All right, you're part of a group, and you've agreed to follow the group's ethical code. And if that's what the expectations are, if it is, you have to abide by that, is what I would say in that situation.
Well, what about a journalist who won't reveal his sources and chooses to go to jail because it's violating his ethics? You could get in the same situation.
You can. Definitely you can. And then maybe something will change. Okay. So when you look at the hierarchy, I already told you you're last on the list. Okay? The patient and the client comes first. The public protection is second. The profession, I already said, you affect a lot of people if you do something. And then we're sort of seen as last. So prepare yourself, ahead of time let the client know the limitations. Let them know your responsibilities. Understand the law. Decide how and when you're going to deal with confidentiality. Develop a plan. Choose reliable, ethical consultants. That you could call on. Devise informed consent forms. Be prepared to discuss this and its limitations. Tell them the truth up front. Tell them about the limitations. Somebody mentioned that earlier with that scenario. And reopen the conversation when circumstances present themselves. Reopen the conversation. All right. Gossip is hard to defend, okay? So in the office, sharing with the colleague is helpful. Gossip is like some specialness or excitement. If you're doing a consult, you don't have to identify the patient. You can give a consult, you can give a description without identifying the patient. Gossip, is not that. If it's made professional to professional, that's a consultation. And it generates this sense of utility with each other, as opposed to gossip is careless. Here's the gifts. I talked about that. Dual relationships. All right, we're at the end of our instrument, and then I'm going to wrap this up. So number 20. Oh, we already did 20. Number 21. I have recommended treatment procedures or referrals that I did not believe to be necessarily in my patient's best interest. 22. I found myself fantasizing or daydreaming about a patient. 23. I've made exceptions for patients, scheduling, benefits, and or fees because I found the patient attractive, appealing, or impressive. 24. I have made exceptions for some patients because I was afraid he or she will otherwise become extremely angry or self-destructive. I made exceptions for some patients because I was afraid he or she will otherwise become extremely angry or self-destructive. Number 25. I have sought social contact with patients outside of scheduled clinic visits. All right. So here's how you score it. For every N, you get a 0. For every R, you get a 1. For every S, you get a 2. And for every O, you get a 3. So just go down your list and add them up. Privately, I'm not going to ask you to raise your hand and share them with anybody in the room. Definitely not. All right. So my question is, what do you think the cutoff is for somebody who needs some consultation? 5? All right. Well, how many people say 5 or less? Or let's say 5. All right. How many people say 10 or more? All right. How many people say 15? If you got under 15, you're okay. 15 or over, you need a consultation. All right. The number is 6. You got 6 on there. So a bunch of you said 5. This is really something called the boundary violation index. The boundary violation index. Bill Swigert at Vanderbilt, he normed this instrument. And what I would tell you is that it's just good examples, okay, to have a discussion about. Not necessarily, the people that I've seen, they would have 25 and 30s on this thing, okay? Because, you know, they're required to have a serious therapeutic intervention. So rural, smaller communities, boundaries are going to be a little different. Dual relationships, very hard. The conflicting roles. Here's how we'll close. Think about what you're doing, why you're doing it. What is your motivation to do it? How will this affect your objectivity? If you start to say, I wish she or he were my friend, not my patient, I'm probably the only one that can help them. These are all dangerous self-statements. You know, the number one rule is know yourself. What are your weaknesses? Be mindful of them. We all have them. You know, things happen in our life. It makes us more vulnerable. It makes us more challenging to have therapeutic and boundary relationships. Listen to your self-talk. Listen to that little voice in your head. And if there's any question like, should I? No, don't do it. So when in doubt, consult, have a written plan, use your office for work, keep good records. So if you're going to go to that bar mitzvah, you're going to go to that graduation, be willing to come back and write it down. You're going to accept that gift. All right? Don't seek emotional support from your patients. When in doubt, when in doubt about self-disclosure, don't. No personal services. No, like, you're going by the post office I saw. Can you drop off my mail? No. Some people have to have chaperones, mostly not us here. Be careful with gifts and touch. Keep good records. Get second opinion. Be willing to write it down. Be willing to be aware of making exceptions and recognize your vulnerabilities. Don't do therapy with friends, financial associates, people in your social and organizational acquaintances, family members, students, supervisees, research participants, anyone who you evaluate, employees, former, current, or possibly future sexual partners. All right. As magically as a kiss can transform certain frogs into princes, a hug can change a patient into a plaintiff, a $40 motel can become a $1 million lawsuit overnight, and a hard-won career can vanish up in smoke, never to reappear. Don't end up outside the tent like this guy here. All right. And Robert Frost said, good fences make good neighbors. Now, in closing, so a colleague of mine and I wrote a book 2 years ago called Taming Disruptive Behavior. The American College of Physician Executives published it. So I'm going to give away 2 copies. All right? I'm going to ask a trivia question that's actually in the book. And if you know the answer, you have to raise your hand. Don't blurt it out. All right? What's the name in 1964 of the Supreme Court Justice who said, I know it when I see it? I know it when I see it. What's the name of the Supreme Court Justice who said this? You got to raise your hand. Marshall, no. Don't Google. No Googling, please. Warren, no. Stuart Potter, exactly. He was the one. He's the one that said it. Very good. Now, I'm sure everybody in the room knows what he was talking about, right? I know it when I see it. What was he talking about? Pornography, right? So that's what the premise behind this book is disruptive behavior. What is that? Well, I know it when I see it is the first chapter. So there you go. All right, one last one. Who said, so a big part of the treatment for disruptive behavior, by the way, it's written for disruptive professionals, okay, in healthcare. And that's what it's really written for. Not the new disruptive behavior that little children have, that we have in the DSM-5. So part of the intervention has to do with a 360-degree feedback system, where if I'm the disruptive person, you're going to rate me, I'm going to rate myself, and we're going to compare ratings. very routinely to see how I'm doing behaviorally in the organization. So what famous person wrote, and this is the last quote in the book, the famous person said, "We do not deal much in fact when we are contemplating ourselves." Now raise your hand. We do not deal much in fact when we are contemplating ourselves. Yes? No, not Cabran. We do not deal much in fact when we are contemplating ourselves. Oh, I gotta have some English majors in here. Mark Twain, very good. Excellent. Oh, okay. So with that, I'll close. Thank you so much. Thank you. I appreciate it.